So I spent the last 10 years of my life in pursuit of a medical breakthrough that has the potential to save millions. And I've worn a lot of hats along the way. I've been an assistant professor at Harvard Medical School. I've been a director of government and nonprofit health programs. I've been an advisor to charities and philanthropies that focus on healthcare. And now, for some crazy reason, I'm trying to build a company in this field. But I'm here to tell you that after working with over 250 hospitals, 1,500 clinics, 20 plus health plans, and a handful of pharmaceutical companies, finally, and for the first time, this breakthrough is happening. But before I tell you about what this breakthrough is, I'd like to introduce you to the patient that inspired my journey toward this goal. Female, age 32, diagnosed with invasive ductal carcinoma, stage 3 breast cancer. No prior history of serious illness, no family history of breast cancer. And so you can imagine my surprise, our shock, our terror, when this, my wife, was diagnosed. I did what any loved one would do, what every loved one is forced to do when faced with a serious illness. I gathered as much information as I could, as quickly as possible, so that I could answer the fast approaching round of life-saving questions that we would need to answer in order to get her healthy again. And what you realize when you try to gather the information required to make these decisions is, despite the fact that a lot of research has been done, it doesn't necessarily answer the questions you need answered to keep the people that you love healthy. For example, there's plenty of research on breast cancer, but most of the research done was done on women ages 55 or older. My wife was 32. We wanted to have more kids. And we could, according to the doctors. We could freeze her eggs, and then we could have children later. But the process of doing so would introduce more estrogen into her body. And the estrogen is the same hormone that was fueling her cancer. So what do? We asked, what should we do? And the doctor said, well, that's a personal decision. We said, of course it's a personal decision, but what does the data say? What does the research say? Well, that question hasn't been answered. I think it really hit me when there was a very active debate between the radiation oncologist and the plastic surgeon over who would get to go first. The radiation oncologist argued that if you insert a tissue expander into the chest wall before she was able to finish radiation, there could be cancer left behind. And the plastic surgeon said, if you radiate the chest wall before I'm able to expand the tissue, she won't have a breast that she's comfortable with for the rest of her life. So what do? So I became very interested as a researcher into just how little do we know, and why is it that we don't know these things? After all, the story of progress for the last 30 years in nearly every other industry is centered around taking data, learning from it, and then delivering more personalized and relevant recommendations. When you log on to Netflix and go to select a movie, and they're recommending to you a movie that you may enjoy, the way they're doing that is they're gathering the data that they have about you and all of the movies you've liked, and then millions of data points of other people like you and the movies they would like, and then they're making a personalized recommendation. Casinos have figured out how to transform their business to use millions of data points to place slot machines in exactly the right place to make as much money as possible. Even waste management has been revolutionized by the ability to use data to optimize routes and to anticipate years in advance when the landfill would be filled. So why not healthcare? What you come to discover when you research this topic is the tragic reality of healthcare today is, despite the fact that healthcare counts, unlike any other industry, it really is the one field that's a matter of life and death. But you'd be hard-pressed to find another industry that counts as little as healthcare. And I mean counts quite literally. Today, healthcare doesn't collect the data of every interaction between patient and clinician and use it to answer the three most fundamental questions of improving the quality of care delivered. And these are the three questions that are being answered by every other industry with their data. What should we do? Are we doing it? And can we do it better? So I became convinced that if we could use our data in the same way that other industries are to answer these three fundamental questions, couldn't data then become medicine's next great breakthrough? After all, there's not a disease or a decision that couldn't be dramatically improved by access to more relevant, timely, and accurate information. So the obvious question then is, if healthcare counts so much, why is it that healthcare is nearly 30 years behind every other industry when it comes to learning from its data? And to answer that question, you need to understand the way healthcare has been paid for in the United States for the last 30 years. See, when you see your doctor today, your doctor, their clinic, their hospital gets reimbursed in what's called a fee-for-service model. And in a fee-for-service model, reimbursement is based entirely on the number of units of care delivered. Nowhere in the formula for reimbursement today, at the vast majority of healthcare systems in the US, is whether or not it worked, how efficiently it was delivered, or how we could do it better. That's not part of the formula that goes into how most healthcare is paid for. And as a result, you shouldn't be surprised to learn that healthcare in the United States is, compared to the rest of the world, by far most expensive. We are first in the world in terms of the amount of money we spend, but we are 37th in terms of the quality of care we deliver. So that's very doom and gloom up till now. But the reason I'm here today is because, as I said, this breakthrough is happening. And it's happening right now. And there's two necessary conditions for breakthrough that simply have not been there in the past. And they are, number one, access to data, and number two, incentive. So over the last 8 years, the federal government has introduced a number of programs that have, number one, incentivized the adoption of electronic health records. So when I started this work 10 years ago, 95% of clinical data was on paper. Now, just 10 years later, 95% of hospitals have electronic health records. So we have data. But data without incentive is completely useless. So during that same stretch of time, a number of policies were introduced that for the first time begin to reimburse healthcare providers based on the quality of care they provide, based on whether or not it worked, based on whether or not patients get healthier, and whether or not that care is delivered efficiently. So, for the rest of my time, I'd like to talk to you about a few projects that I've been very lucky to be a part of that I think give us a window into what the future of healthcare might look like. And in order to do that, you need to look at places where healthcare has been delivered that have already had both data and incentive for some time. And when I say the future of healthcare, I mean a future in which data is routinely used to answer these three fundamental questions. What should we do? Are we doing it? And can we do it better? So let's start with question number one, what should we do? And by what should we do, I mean when you, the patient, are sitting across from your provider, and the two of you are trying to make a treatment decision, treatment A versus treatment B. What evidence do you have? What science has been done? What does the data say about what should you do? So in order to tell the story of what healthcare may look like when we use data in very different ways to answer the what should we do question, we need to travel up the road a bit to the VA Boston Healthcare System. VA, that's Department of Veterans Affairs. So I know what you're thinking. Groundbreaking medical innovation using data in innovative ways. This must be a story about the federal government. Or maybe you're not, but you should be. Because the Department of Veterans Affairs has had data and incentive longer than any other healthcare system in the United States of America, and as a result, an enormous amount of medical innovation, particularly data-related medical innovation, come out of the VA. They've had electronic health records for over 30 years, They've also had incentive because they get a fixed amount of money from Congress to deliver care as efficiently as possible. So they've been conducting a number of innovative programs to figure out how to use their data to deliver care. So the one project I want to talk to you about is about answering that question, what should we do? So the way we answer the what should we do question today in healthcare is through clinical trials. And if you become part of a clinical trial, you're sort of picked up out of the routine clinical care world and dropped into the clinical research world, right? And this is a separate enterprise with different people caring for you, collecting different types of information and sending it off to different information systems. And the challenge with this particular model is that it can take years and hundreds of millions of dollars to answer 1, 2, sometimes 3 questions at a time. Now, because it's so expensive, we typically only use this model to bring drugs and devices to market, but that means that there are millions of questions that go unanswered because we simply can't conduct a clinical trial to answer them. So what the VA is doing that's very different in this space is they're saying, what if we took this clinical trial mechanism and we boiled it down to a piece of software? And then we took that software and we jammed it inside the electronic health record, that same computer system that the doctors are using in clinics to care for patients. They started with a simple but important question that we don't have the answer to, which is, if somebody you love is diagnosed with diabetes, should they get weight-based dosing or should they get sliding scale dosing of insulin? We don't know the answer to this, and it's one of millions of questions that we can't afford to run a large clinical trial to answer. But here's how this works now at a number of clinics in the VA. The patient sits across from the doctor. They both decide that insulin should be prescribed. The doctor turns to the computer and makes an order for insulin, but a window pops up, and it says something to the effect of, we don't know what works best, weight-based or sliding scale. But we're running a trial right now, and if you're willing to participate, then we will assign one or the other to your patient. And a clinical trial will unfold behind the scenes as part of routine care. So what does this mean? It means that we've shrunk down the amount of time it takes to conduct a clinical trial to a fraction of what it takes today. And we've shrunk down the cost of conducting that trial, which means that we can generate far more evidence far quicker than we've ever been able to do in the past. Or put another way, we will have more answers to the what should we do question. Now, if we can do this in the federal government, which, as you indicated, isn't famous for innovation, imagine what happens when the rest of healthcare is incentivized to use its data to answer the what should we do question far more quickly and accurately than they can do today. Thousands of new ways of learning will be introduced, and that's a really exciting potential breakthrough. Okay, question 2, project 2. Are we doing it? What I mean by that is when we have the answer, are we consistently putting it to work for our patients every single time, right? Well, the answer to that question in the US is, we don't know. This is not something that we capture as part of delivering care in the US because we haven't had incentive to do so until quite recently. But if you want to see what that might look like, let's travel to the other side of the world, Uttar Pradesh, India, where the Better Birth program is taking place. And this is a project run out of Ariadne Labs, led by Drs. Catherine Semerau and Atul Gawande. And the idea of it is this. There are 19 best practices that we know save babies' and mothers' lives during childbirth. So let's put them on a piece of paper, a simple checklist. Let's have the coach and a birth attendant. The birth attendant is what we call the people that deliver babies in India, and the coach is someone who will have the job of picking which best practices we're going to be working on for the next week. So they may pick something like hand washing, skin-to-skin contact, breastfeeding, really basic behaviors that lead to healthier babies. Then the birth attendant gets to work, and the coach steps back. And here's where data comes in to help us understand, are we doing it? The coaches have a tablet, a $60 piece of hardware. And with that tablet, they're just counting. So they decide that the birth attendant is going to work on hand washing. And if the birth attendant washes her hands before delivering a baby, green, If it takes a bit of prompting, yellow. If the birth attendant doesn't do it, red. So instead of just telling somebody what to do or training them in how to do it, the next time the birth attendant and the coach get together to talk about how it went and whether or not we did the right thing every time, they can look at the data. This is a data feedback loop and a really simple mechanism of doing so. So if we can do this in a part of the world that is incredibly resource constrained with a $60 device, and this has now been rolled out across 120 clinics to observe and improve over 70,000 childbirths, I have great confidence that we can do this in the United States of America, and we soon will. Third and final question and project, can we do it better? So in Projects 1 and Project 2, we were talking about programs that were funded by the federal government and philanthropies, because that's where the incentive has been. What's exciting about this next project is it's an early example of what you can do in the US healthcare system when the incentive and the data becomes available and important. So this project is part of a collaboration between Senior Whole Health and Cyft, the company that I'm building now. And Senior Whole Health, as the name would suggest, is responsible for keeping a population of seniors healthy. They're out of Massachusetts, and I believe they do have patients here in New Bedford. And the idea is very similar to what Amazon or Netflix are doing today. What if we took all of the data of our patients, and rather than try to predict whether or not they'll buy a book or click on an ad, let's use their health data to predict whether or not a bad thing might happen. So for example, what if we took all of the data of patients that have experienced falls, which is a terrible thing to have happen, and we used the signal in that data of what seems to be the pattern leading up to a fall. We can use that to tell the nurses that are caring for these patients that, hey, this person might be at a higher falls risk, so that when the nurse works with the patient or goes into the patient's home, they can be aware and they can look around for things that are falls risks. Does the patient have proper fitting shoes? Do they have a walker? Is the furniture in their homes arranged in a way which minimizes the likelihood of falls? So I hope with these last three projects, you're thinking beyond, hey, this is cool stuff happening in childbirth or diabetes or with falls risks. I hope that the message is, when we start to use our data in different ways, we can begin to answer these questions and we can begin to really improve care. Because again, appropriate use of data really isn't disease specific, right? If we can use our data properly, there's no shortage of the number of questions we can answer. And with no shortage to the number of questions we can answer if we use our data properly, you can see why I'm enthusiastic, and I hope not overstating it when I say that data has the potential to save millions of lives. But when we use words like millions and data and breakthrough, it becomes easy to forget why we do this. So there's my wife, and now 2 beautiful children. Thank you. I just get half the credit. As of December 20th, we will be 9 years post-diagnosis. We do this work, and we need our data to be put to use so that when someone you love is forced to make really difficult decisions related to health, you deserve, and your clinician deserves, access to the most timely and relevant and actionable information possible. And now, because of the way we're just starting to use our data, you soon will. And when you do, you'll know for the first time and finally, your healthcare counts. Thank you very much.